This is how I do my neck pain exams, part 1.
So for part 1 of my neck pain exams, I'm going to show you all what I do with the patient in the sitting position. For efficiency and patient comfort, I try to break up all my tests to minimize position changes. So always start with the upper quarter screen, and that includes reflexes, sensation, and strength testing. And the upper quarter screen does one of two things. It essentially gathers information about red flags that might deem this patient not appropriate for physical therapy management, as well as identifying potential impairments that the person might be dealing with because of their condition. Things like hyporeflexia, dermatomal sensation changes, individual muscle weakness can provide all good information about the person's condition. So that's why I screen these 3 things first. I'm going to speed through the strength testing a little bit here because it gets kind of redundant, but basically just making sure I hit all the myotomes and major muscles of the upper extremity and comparing side to side to see if there's any asymmetries. After I'm done taking muscle tests, I'll move to a cervical active range of motion screening. So I'll have the person flex, extend, rotate side to side, and laterally flex side to side. Again, this is just a screen, so if I notice any visible deficits, I'll grab a goniometer and take the formal measurements here. Then while the person's sitting, I'll do a quick Sperling's test, particularly if they're reporting symptoms going into their arm, or if I noticed any myotomal weakness or dermatomal sensation changes in my initial screen. So next is a really important part of the exam that I feel like is oftentimes overlooked in people coming in with neck pain. It's super important to screen the shoulder in people with neck pain because the shoulder girdle can refer pain to the neck and vice versa. So this is where I'll knock out some shoulder special tests to aid in differential diagnosis. So I'll check a painful arc sign like you just saw, then I'll do a Hawkins-Kennedy to see if that reproduces any pain. And then depending on the response to those tests and what the patient was reporting to me subjectively, I might knock out a Nearest test while they're here and an empty can test. And yes, I know these shoulder special tests aren't the best, but at least they can help clue you into if pathology is truly at the shoulder if you are thinking shoulder girdle referred pain to the neck. And then last but not least, I will always screen repeated movements of the cervical spine. I talk about this a lot with low back pain, but repeated movements of the cervical spine can be an effective intervention to help the patient self-manage their condition. Because when it works great, but I try not to push the issue if the person doesn't seem to be responding. So I'll have the person do repeated protrusion and retest any asterisk signs if I need to, and then do repeated retractions and retest any asterisk signs if I need to there as well. And that's it. And that's a lot of information that I gather while the person is in one position, and that can help make a clearer clinical picture for me. I've found it's pretty efficient and doesn't take a ton of time. Stay tuned for part 2 because I do have another video coming out that shows how I do the laying portion of the exam. Follow me for more PT tips.